You are at the front line of life-saving medicine. From managing mechanical ventilation and advanced oxygen therapies to navigating complex critical illnesses, this is a field where precision and expertise define outcomes. To excel, you need more than knowledge. You need mastery in applying it under pressure when every second counts. Elevate your expertise. Apply for the fellowship in respiratory critical care. This program empowers you to master mechanical ventilation, advanced respiratory support, and critical care strategies for patients with the most complex conditions. This is not just another training, it's a transformative experience designed for ambitious professionals determined to redefine their practice and impact. Learn from world-renowned experts. Gain clinical insights, practical pearls, and the latest evidence, all accessible from wherever you are. Our curriculum is comprehensive, covering the full spectrum of respiratory and critical care, from invasive and non-invasive ventilation, ARDS, and sepsis management, to ECMO and advanced rescue therapies. You'll gain practical, actionable expertise. Engage in live, interactive sessions, present your toughest ICU cases, collaborate with peers across the globe who share your passion for saving lives. This is your chance to strengthen your expertise, expand your career horizons, and join a community dedicated to excellence in respiratory critical care. The future of respiratory critical care is here. Are you ready to lead it? Applications are now open. Visit our website to begin your journey today.
Hello, and welcome to our Respiratory Critical Care Fellowship Program, which is very unique flagship program structured as 3 modules, 16 weeks each. Every week you will have lectures, a journal club, MCQs, and clinical case scenarios. And we are teaching you to master the field of respiratory critical care. We gathered international expertise from all over the world to give you high quality educational materials. And again, this is not based on lectures or monologues, but rather dialogue, and we are involving our fellows in the teaching process. All of our fellows' activities and assignments are monitored in a smart platform, and there will be a weekly quantitative and qualitative evaluation, not only based on their scores, but on their engagement and overall performance throughout the whole year. Module 1 of the fellowship is focusing on foundations and the basics of respiratory critical care, from basic anatomy, physiology, pharmacology, blood gases, acute severe respiratory tract infection, status asthmaticus, introduction to respiratory monitoring with pulse oximetry, capnography, and a lot of emphasis will be given on the imaging, especially the CT scan and point-of-care ultrasound, and of course, traditional, conventional, and novel imaging modalities. Module 2 will be basically focusing on oxygen therapy and ventilation. We'll teach you the fundamental of oxygen therapy, non-invasive ventilation, waveform interpretation, difficult weaning, and invasive mechanical ventilation. Module 3 will be dedicated to advanced topics, including non-conventional mechanical ventilation, nutritional support, and respiratory critical care field, extracorporeal membrane oxygenation, extracorporeal CO2 removal, electric activity of the diaphragm, advanced monitoring of the esophageal balloon. All of these high quality education will be delivered through e-learning. We'll deliver all of this material through a smart platform. All of our fellows will have username and password, and will have 24/7 access to the scientific material throughout the whole year. Again, one of our major aim is to identify our fellows' weaknesses and to improve their performance and to help them to implement the up-to-date information of the respiratory critical care field in their practices. Upon completion of this fellowship program, our fellows should be expert in the respiratory critical care field and should graduate to a trainer mentor level and should receive American Association of Continuing Medical Education certificate upon successful completion of the program. So please, if you haven't joined yet, join our international fellows and international board in this very advanced and smart fellowship program. And try to take advantage on this discount. You can get 10% discount using the promo code of webinar 10. So, as you know, knowledge has no values unless we put it in practice. So the great aim of education is not the knowledge itself, but the action. So hopefully we are going to implement this clinical knowledge and improve our patient care and our patients' outcome. Welcome everyone to our very special webinar today. It's very special to us because we are focusing on a very pivotal problem that we are facing in our ICU. And our big question that we are trying to answer today is, can we improve our patients' outcome by applying early ambulation and mobilization strategies? As you know, that from Professor Heba a couple webinars ago, she gave us very nice presentation about the critical care bundle, how to improve our mechanically ventilated patient outcome by using the ABCDEF bundle. And the E stands for early mobilization and exercise. We have received a lot of questions about how to apply and how is it safe to do this in our mechanically ventilated patients. So we dedicated this webinar trying to focus on the methods, the safety, the benefit of early mobilization, hopefully to improve our mechanically ventilated patient outcome. We have great speakers, panelists today. We have Professor Hebatullah Asal, Professor of Chest Medicine from Cairo University, Dr. Mustafa Fadel, he is a critical care physician in Saudi Arabia, Aaron Thrash, physical therapist in Abu Dhabi, Dr. Hisham Faisal, he is a senior consultant in Kingdom of Saudi Arabia, Dr. Muhammad Al-Ammari, he is also a senior critical care physician in United Arab Emirates, and we have Dr. Murad Baba from United States of America. So again, great speakers, great panelists and moderator today. And here is our agenda. We are going to start with 20-minute presentation by Dr. Mustafa Fadel, then another 20-minute presentation by Aaron Thrash. Then we will have the case-based discussion for 10 minutes by Professor Hebatullah Asal. Then Dr. Hisham Faisal and Dr. Muhammad Al-Ammari with Dr. Murad Baba are going to moderate this session. Without further ado, I will let Dr. Hisham Faisal to introduce our first speaker, Dr. Mustafa Fadel.
Thank you, Prof. Amr. for invitation. It is my pleasure today to present Dr. Mustafa Fadel. Dr. Mustafa Fadel, he is a senior cardiac anesthetist, and he's the head of the anesthesia department at Saud al-Babtain Cardiac Center. And actually, Dr. Mustafa, he's our champion in Iraq's program. And Iraq's stand for Enhanced Recovery After Cardiac Surgery. And one of the very important tasks of Iraq's is early mobilization. And we are trying to do this very early post-operative cardiac surgery within first even 6 hours, even while the patient is intubated and underwent a major surgery. So without any further ado, I will ask Dr. Mustafa to give us his talk about does the mechanical ventilations means that you let the patient completely immobile in bed or if there is in a room, and what is the evidence about it? And I will ask Dr. Mustafa to start his presentation now. Thank you.
Yes, thank you. السلام عليكم ورحمة الله وبركاته. I'm Dr. Mustafa Isam Fadel, cardiac anesthesia and ICU consultant, Saud al-Babtain Cardiac Center. Thank you, Dr. Hisham, for introducing me in a gentle way. And it's my pleasure today to be with you to share evidence-based mobilization of mechanically ventilated ICU patients. For disclosure, nothing to be disclosed in this lecture. And we'll start with this picture. Whenever you think about the ICU, the old school was the patient is lying on his bed. If he's lying flat, restless, and he cannot fight, the advice was not to fight the serious disease you have, the sepsis, the trauma the patient is having in the ICU. For mobilization was in all decades that harmful for the patients. But what we are going to show in these few slides, following few slides, the opposite, how to early mobilize the patient and the evidence behind the patient mobilization in ICU. First, we have to define mobilization. It's a continuum, starting from passive range of movement up to ambulating the patient walking with or without assistive device. And in between, the patient can be active in bed, can sit upright with or without assistance, or stand weight bearing at the bedside, or even high stepping in place to build endurance to get the last target, which is ambulating unassisted. The most deleterious effect of the ICU, the immobility inside the ICU is the ICU acquired weakness, which is critical illness combined with myopathy and polyneuropathy. And it's a phenomenon in rapid muscle loss. There is decrease in the quadriceps cross-sectional area per day, more than from 1 to 3% per day. And when we are talking about the mechanism of the ICU acquired weakness, it's multiple mechanisms. Maybe protein imbalance, discrepancy between the synthesis and degradation of protein that cause muscle satellite cell impaired generative ability, mitochondrial dysfunction, altered cytoplasmic reticulum, and also it's accompanied by neuropathy and abnormal electrical excitability. About the risk factors for ICU acquired weakness, we can categorize into modifiable risk factors and non-modifiable risk factors. For modifiable risk factors, I think most of us know it: hyperglycemia, parental nutrition, drugs like excessive use of vasoactive drugs, long use of neuromuscular blockers, corticosteroid sedatives, and certain antibiotics, especially aminoglycoside and vancomycin, and our core topic, which is immobilization, and the other non-modifiable risk factor out of our hand, like severity of the disease, sepsis, multi-organ failure, female sex, high lactate, older age, and pre-morbid functional status. When we are talking about the evidence behind the early mobilization in the ICU, There are a lot of randomized controlled study, but the most important and most recent network meta-analysis of 43 randomized controlled studies results published in 2023, and they concluded that mobilization started within 24 to 72 hours of admission was the most effective time frame for reducing ICU-acquired weakness. And also another published very recent study, which is already published in 2025. There was meta-analysis of 16 randomized controlled studies, included more than 2,000 patients inside the ICU, and they found that early mobilization within 72 hours of admission significantly reduce ICU length of stay, mechanical ventilation. Early mobilization doesn't also increase the adverse event or mortality. The other deleterious effect of immobility inside the ICU is delirium. A systemic review published in 2023, it was meta-analysis published by Nidal and his colleagues in intensive care and critical care nursing. They analyzed 13 studies involving more than 2,000 patients, and they concluded that early mobilization significantly reduced the incidence of delirium by 47% compared to standard care. And also for patients that already experiencing delirium, mobility intervention shortens the duration by about 1.8 days. Let's head to our core topics in this lecture. The guideline on positioning and early mobilization in critically ill patients. It was guidelines published by the German Society of Intensive Care and Austrian Society of Intensive Care. I chose this guideline because the methodology for this guideline was very significantly meticulous in evidence-based documentation, in number of abstract and studies they gathered in their guidelines. It was evidence-based documentation focusing on positioning, mobilization, and the device, and they screened more than 14,000 abstracts, and they included in their guidelines 446 studies. They came out with 46 recommendations as results of rigorous multi-stage Delphi process involving 23 international experts. And they put it into 4 sets. The first set of recommendation, upper body elevation rationale. They concluded that it reduces VAP, improve ventilation, may increase pressure ulcer. And the first recommendation to increase the head of ICU patient more than 40 degrees. But in patients with increased intracranial pressure, you should be individualized by monitoring the cerebral perfusion pressure and the intracranial pressure. Maybe you can put your patient flat or 15 degrees or 30 degrees according to monitoring cerebral perfusion pressure and intracranial pressure. Then you have to make regular modification and avoid fixed position for the patients. About lateral position, which is suggested, in normal patients, there is no recommendation for lateral position. But with unilateral lung damage, put the good lung down to improve VQ mismatch. Don't put your patients flat, and when you are trying to elevate the head of the patients, don't make knee flexion, and avoid patient with, especially in patient with elevated intra-abdominal pressure. So how can we make the upper body raised for more than 40 degrees without neck flexion? By using anti-Trendelenburg position. Second set of recommendations about the proning position. You have to start proning when the PO2 FR2 less than 150 mm mercury. Start the proning position early after indications. That means, what does it mean early? That means within 48 hours after the indication. And prone at least 12 hours, ideally 16 hours, Q 24 hours. And about the operational parameters, they came out with a lot of recommendations. What ventilation strategy we can use in proning position, protective lung strategy, and we can permit spontaneous breathing in proning position. You have to optimize volume status before turning, and catecholamine can help you in proning position, and it's not a contraindication. What about stopping? When should we stop the proning position? If we succeed, if we fail. What does it mean if we succeed? That means terminate if the oxygenation of the patient improve more than 4 hours in spine position. What does it mean? PO2, FR2 more than 150 millimeter mercury in spine position more than 4 hours. On moderate ventilation settings, PEEP less than 10, FR2 less than 0.6. And also we can stop if we failed. We can discontinue after 2 unsuccessful attempts and no oxygenation improvement. You are now just taking the disadvantage of proning position. Other recommendations for the patient, the prone patients, consider abdominal surgery or obesity should be individualized, benefit versus risk, and monitor intracranial pressure during prone, keep head midline, avoid prone in open abdomen, unstable spine, and shock, and inspect for skin ulcers for new pressure point in proning positions. They recommended also to make a complete proning position 180 degree. And this is the scene of our operational plan should be started as early in within 48 hours after indications, minimal 12 hours, and this is the exit when PO2, FR2 more than 150 millimeter mercury. Patient should be fully proned, and you can stop if you failed in two successive sessions. Type. What about awake proning? They recommended that in non-invasive ventilated patient with acute hypoxic respiratory failure is COVID-19 patients, there is a strong recommendation about proning these patients, but they were unable to make recommendation in non-COVID patients. And I think all of us proned some COVID patients as we experience it. Type. The last recommendation for proning position in VV ECMO. They couldn't get a recommendation with or without or against the proning VV ECMO. It's individualized, and a lot of debates about proning patient in VV ECMO. For me, yeah, you have to see in the CT scan bilateral basal lung atelectasis clear that the patient can benefit of proning position on VV ECMO. The third set of recommendation is mobilization of the patient in the ICU. First, they started with the recommendation of early mobilization. As we figured out the evidence base about early mobilization, they recommended that to mobilize the patient early within 72 hours inside the ICU. And we have to categorize our patient with functionally independent before ICU admission and functionally dependent, especially in patients with functionally independent before ICU. There is a strong recommendation to mobilize them, and weak recommendation for the patient who are functionally dependent before ICU admission. Then, hospital management must provide the personnel and material condition to enable early mobilization. CRRT, renal replacement therapy, it's safe to mobilize after consultation, adverse event rate less than 2%. And with patient with ECMO, Yes, also it's safe. Mobilize after team consultation in experienced center. Adverse event less than 4% and accidental canal displacement is rare after achieving the training or learning curve. For neuro ICU mobilization, it requires progressive approach and specific timing considerations. Patient with subarachnoid hemorrhage mobilized after multidisciplinary consultation. Benefit, it's evidence-based in their guidelines. Progressive protocols are safe and reduce VAP and length of stay in this patient, but avoid to mobilize patient in recent acute stroke, that means within 24 hours of the stroke. And they strongly recommended to follow protocol-based stepwise progression to the highest possible level, starting from passive mobilization, active assisted, and then active mobilization, and to prepare a checklist to inform the patient, secure and extend artificial airways and IV lines, provide sufficient staff, and adjust alarm limits. For about some scores in or protocols in our ICU, we have ICU mobility scale, which focus on active mobilization. It's 11-point score, starting from nothing, which is 0, scale of 0, and end up with walking independently without a gait aid, which we can score it as or give him 10 over 10. It promotes high. You have to promote for high levels. And another important protocol which we are applying in our facility, Saud Al-Babtin Cardiac Center, it's a surgical ICU optimal mobilization score. Started from passive and also active movement, from no mobilization, passive range of movement, sitting, standing, and ambulation. طيب, how to implement our protocol like SOMS protocol? Daily goal setting. You have to set during morning rounds. The medical team uses the SOMS algorithm to set mobilization goal for the next 24 hours. Now we have to set the patient at the edge of the bed. Now we have to make the patient stand or few steps or whatever your target. Then safety checks. Algorithm include yes or no questions about the hemodynamics, if the patient is stable hemodynamically, or another question like the intracranial pressure is less than 20 centimeter mortar or above. Bedside execution. A sign is often posted at the bedside indicating the day's goals, and the nursing staff works with the patient to achieve it. Documentation. Nurse should document the highest score, the highest protocol level achieved daily, and the barriers if goal not achieved. About safety considerations, recommended to put the safety as a priority, ensure hemodynamic stability, secure airway lines, and train your staff. And when to stop to mobilize your patients if there is significant hemodynamic instability, like decreasing in SpO2 less than 86%, increase heart rate more than 30%, mean arterial blood pressure less than 60 millimeter mercury, or significant increase in blood pressure also should be considered, like increasing systolic pressure more than 40 millimeter mercury, intractable pain in spite of painkillers, and acute delirium or acute disturbance of level of consciousness. Also, they recommended to put mobilization as a key component of A, B, C, D, E, F bundle for ICU preparation. We finished now 3 sets of recommendations. The first set is upper body position, second pruning position, third mobilization, and the fourth and the last set, which is technology, using technology during mobilizing the patient inside the ICU. They couldn't conclude with or against the use of supine cycling. Consider when functional training isn't possible, And during supine cycling, monitor intracranial pressure. Cycling can raise the intracranial pressure. And also, this is the same recommendation in new electrical stimulation. Mixed results, some benefit for muscle strength, others show no difference, and warning of increased intracranial pressure. So you should monitor intracranial pressure. Uh, just a few points um, to remind you during your daily work. Positioning and mobilization are essential. Follow evidence-based guidance, put protocols for mobilizations, and follow these protocols. And after that, for special cases, individualize the care for the patient. Thank you very much for your attendance.
Thank you very much, Dr. Mustafa, for your elegant presentation. So as we have here, there is good evidence for mobilization within 72 hours. There are some obstacles, and we are going to hear from our next speaker, Mr. Aaron Thrash. He's a senior critical care physical therapist, and he's education specialist working at the Cleveland Clinic, Abu Dhabi, and he is going to show us some the tips and the tricks about mobilizing patient from a physiotherapy point of view. And I believe there was one question here about questioning that the physiotherapists are arguing against because of fear of tachycardia, shooting blood pressures. So let us hear from Aaron what he's doing.
Thank you for the introduction. I'm happy to be here. As mentioned, this lecture will focus on how to implement early mobilization in the ICU. After that, very nice presentation of evidence behind why we should be doing it and how to do it. I do have about 17 years of experience as a physical therapist, with most of the last 10 to 12 in critical care settings in the US and the UAE. And I'm happy to present today so that our participants will be able to summarize evidence about the barriers to early mobility, discussing strategies on how we can improve our performance, and then I'll share some patient stories that hopefully will be inspiring and maybe generate some questions. I do have a disclosure. I'm a clinical trainer in addition to my day job with VitalGo Systems, which is a company based in the US that makes verticalizing ICU beds. That won't come up at all in this lecture. So I will forego this, but my thought was to have a survey so I can understand. I think we have nearly 300 people on the call. So understanding people's backgrounds professionally, as well as the barriers that people in the audience have experienced themselves, and perhaps what successful interventions they've seen work and been a part of, or additionally unsuccessful interventions. For the sake of time, we will skip this and go right into a good summary of the barriers and strategies for early mobilization. So this is a paper that was published 10 years ago, so it's not very new. However, these barriers largely, in my opinion and experience, have not changed much over the last decade. What this paper does very nicely is present the different barriers in 4 different categories. So it's helpful to think of the different categories of barriers that you and your team may be experiencing. So for example, table 1 of this paper introduces patient-related barriers. So these are things like the physical barriers of the severity of illness that the patient is in, their hemodynamic instability, respiratory instability, pain, obesity, and then the neuropsychological barriers, sedation and paralysis, delirium, agitation, patient's refusal or anxiety, and fatigue, as well as the ICU devices and equipment. So in some cases, there's a perception that lines and tubes and monitoring devices and drains and all of these, even life support devices are barriers. So what's helpful in these tables is you can see on the left side, there's a list of barriers that are related to the patient. And then there are strategies with references to papers. So you can easily find a barrier and the strategies and go back to this paper to find references that will help you know how you might be able to address those specific barriers. So the second category that they present are structural barriers to early mobilization. And this is a very real thing that we all experience, I think, which is limited staff, limited time, and a lack of early mobility protocols, limited guidelines, and not having an eligibility criteria. Now, guidelines and evidence are clearly becoming much more robust, and we know much more than we did 10 years ago. But at a individual center level, establishing and implementing the protocols that are unique to your setting is still a challenge for many people. Inadequate staff training, limited equipment as well. And we'll spend more time actually in the slides discussing the strategies for these. Table 3 is the intensive care unit cultural barriers, and this is very much studied, again, over the last 10 to 15 years in particular, to understand what the culture in our ICUs, how that can present a barrier or be a facilitator when it comes to early mobilization. So when we talk about the culture of an ICU, that means the level of staff buy-in that there is, the multidisciplinary culture, from communication to a lack of staff knowledge and expertise about the risks and benefits of mobility, simply not prioritizing early mobility. Certainly in a very busy and complex environment, it is sometimes easy for mobility to take a backseat. And that's reflective of the culture that people create in that ICU. And the fourth category that these authors suggest are process-related barriers. This comes down to teamwork, essentially. The planning and the coordination that does take a lot of effort to get an early mobility program off the ground, and as well on an individual patient basis to make an early mobility strategy successful for individual patients. Sometimes there are unclear expectations, roles, and responsibilities. The screening and the eligibility may be missed or may be delayed, or you might be facing a process-related barrier such as bed rest orders that are commonly in place. So I think very important when we start to talk about these barriers is to understand that I've just mentioned maybe the majority of barriers in some shape or form that you may experience, but every ICU is unique in the culture that exists, the type of patients that you see, the resources that you have. So this is a survey, the Patient Mobilization Attitudes and Beliefs Survey, ICU version, which in this paper from 2020 adapted the prior survey, which was a ward-based survey, and adapted it into an ICU survey. It is, I believe, 26 questions. And in this study, they validated it among 163 non-therapy medical ICU staff. So people respond with a 5-point Likert scale. There's a total barrier score, and then 3 subscales around knowledge, attitude, and behavior. And each of these subscores gets scored from 0 to 100, with a higher score indicating greater barriers. I have a link to the Johns Hopkins OASIS website where you can download this as well as many other resources on this topic. And again, I think it's really important that when you're working towards establishing and improving the mobility program, we really try to understand what the unique barriers are in the ICU that you're working in. That can be done informally in discussion and focus groups and in just asking questions around the unit, but probably much better to have a systematic approach and even be able to compare your results with other published literature to see where your strengths and weaknesses are. I have just this one slide here on ICU acquired weakness. We've already had an overview of it in the last lecture. This was published in 2025, and you can see the author names, if you're familiar with this topic, are some of the most active researchers in the world who came together to write a really good review of ICU acquired weakness. the epidemiology, diagnosis, risk factors, implications, prevention, and the effects of early mobilization. So I'm just putting this out as a reference. Of course, for our ICU survivors, probably the worst outcome is these patients who develop ICU acquired weakness, and they can go for months and years, as evidence shows, with physical dysfunction, cognitive dysfunction, psychological dysfunction, impact their ability to return to work and their prior roles and relationships. So understanding this topic and how we can prevent this from happening is very, very important to the work that we're doing. The last paper that I'm going to talk through is this paper called 10 Strategies to Optimize Early Mobilization and Rehab in the ICU. Some of the same authors as the last paper, actually. And this, to me, is a really good overview of all the strategies that we can implement to tackle these problems that we've identified. So they have a nice figure here which shows these 10 things and how they can optimize early mobilization and rehab. So I will go through each one. The first one is creating a multidisciplinary team with champions. So something that does have very good evidence and anecdotal evidence as well is establishing champions from a variety of stakeholder groups in your ICUs. Definitely you need physician champions, nursing champions, and champions from therapy and other allied health. People who have the passion, the knowledge, the expertise to drive all these small programs, small initiatives that contribute to the larger efforts of what's trying to be achieved. We should be using structured quality improvement processes. So from the many things that exist, such as PDSA, using fishbone diagrams, a root cause analysis, lean methodology, Six Sigma, having more of a structured approach to these quality improvement projects is very important. And I would encourage people to also partner with their QI teams in their hospital if they have those resources to really get professional help, as this topic is very complex. And I'll just add quickly that we've really looked at our A through F bundle in our hospital in the last year, and from all of the letters and what they represent, we found that this exercise and mobility is one of the most complicated to understand and to implement. So getting resources from the hospital is very important. We need to identify the barriers and implement facilitators. For example, using surveys that help you understand the strengths and weaknesses, the culture, and the perceived barriers in your unit. And I think there's a lot of value in looking at perceived barriers, because even if they're not barriers or they shouldn't be barriers, if they're perceived to be barriers, they are affecting the programs of mobility that you want to have. So using data as much as you can. We need to be promoting multi-professional communication, and this is where purposeful rounds comes into play, and we'll talk about this in a few minutes. But really figuring out how the MDT can communicate and integrate therapy as much as possible. Daily goals and achievements is very important. So as we've seen, the ICU mobility score, for example, that was shared in the last lecture, there's other scales that are similar. And what's being done now in some ICUs is to establish a daily goal for each patient, and then at the end of every shift or every 24 hours, indicating what was actually achieved in terms of mobility. So if your goal is a 4 at the beginning of the shift, what was actually achieved at the end of the shift, and collecting that data can tell you a lot of information. We need to understand patient preferences, and this is where we can use the environment. We can use about me boards and this is me boards in the patient room, so that people on the care team can understand something about the patient and keep the patient at the center of what's happening, setting goals with the patients and the families so that they're really engaged and understand what they're working towards, creating patient schedules, and again, really looking at that environment of care to facilitate rest and engagement from patients. We need to adapt safety criteria. So again, nobody needs to start from scratch in this field. There are plenty of professional guidances and publications that you can adapt for your setting. So you need inclusion and exclusion criteria, screening processes, policies and procedures, and training and competencies established. We need to look at the bundle. The A-Ref bundle is, of course, the most common bundle. And this, I believe, is really physician-led, and it's very important that your physicians are on board with this, because through the bundle, they're setting the stage for successful mobility to be possible. If patients are sedated, not awake, if they're not doing the spontaneous awakening and breathing trials, if their pain and agitation is not managed properly, starting with the physician, it is very, very hard, of course, to initiate any mobility. We need to look at obtaining the necessary assistive equipment. The basics of mobility DME, including bariatric equipment, having a variety of chairs for the variety of patient needs. And of course, there are some capital expenses that will be, if not required, will really, really enhance what you can do, in particular with certain subgroups of patients. And these are different kinds of beds, tilt tables, cycles, leg press machines that are really able to meet the needs of critically ill patients. In terms of the optimal timing and type and dose of intervention, this is certainly not well defined and well described. We don't have a lot of evidence regarding timing and dosing in terms of how many days a week, how many minutes, how do you measure the intensity. The benefits and what I enjoy about being in the ICU is we have a lot of information to guide us, from the bedside monitors, lab values, a team of people around us. And we partner those numbers with the observation of the patient and the symptoms from the patient. So there's a lot of information to guide us in a patient scenario, although from an evidence perspective, we don't have a great idea of the dosing. I think that as physical therapists, and as if you're physicians or whoever else on the team, you should be challenging the physical therapist to be able to justify, are you underdosing? Are you possibly overdosing? How do you make sure that the level of exercise and interventions are meeting the patient's needs in the right way? And this does require creativity and adaptability at times. The final intervention and recommendation is to regularly evaluate outcomes and performance. So I've mentioned here learning health systems. And if you're not familiar with what that is, it's essentially health systems that are used to using very small, quick, rapid cycles of improvement through the use of data and actioning that data. So small changes ongoing, reviewing the data and making a change, reviewing data and making a change. So this is collecting and analyzing data and also getting the feedback on your outcomes out to stakeholders so that you can get even more support. So as an example of the effectiveness of one of these strategies, this is a paper from a hospital in Japan that looked at how to enhance early mobilization through multidisciplinary rounds. So there was a baseline period before the intervention, and then the intervention that they applied in the second phase was to have daily multidisciplinary rounds every morning. 5 to 15 minutes were spent per patient. The evening before, the intensivist would communicate when they would start, where they would start, and then the participants would come the next morning. They would each contribute their daily treatment goal from the different disciplines in order to make sure that they're aligned. The team would consider whether a PT referral was needed based on specific criteria. And besides the MDT, there was training for staff around their early mobility protocols, criteria for when to discontinue, discussions about evidence-based practice during the rounds, and the physical therapists were also instructing the nurses around how to improve their own mobility techniques. So this graph shows in blue the proportion of patients that were mobilized early each month. And so you can see that in the first few months before the intervention, around 0 to 20% of patients were mobilized each month. And that was an upward trajectory until the end of the program, where 40 to maybe 75% of patients were mobilized. So a very dramatic increase. And then the orange line is the days that it took to start physical therapy from ICU admission. So in the beginning, we would have 5 to 15 days before physical therapy is initiated, and this came down to about 3 to 5 over the course of the intervention. This table shows the characteristics and the outcomes from phase 1 to phase 2, and I've highlighted any of those that are statistically significant. So we should recognize that actually the patients in phase 2 were less sick according to the Abachi 2 score, so that may be confounding things a little bit and requires a deeper look to see how much that may have had an effect. But even the duration of mechanical ventilation went from 7 days in the first phase to 2 days in the second phase, and that again, it may be both underlying difference in the groups, but maybe perhaps an effect of the mobility program. But then in terms of the outcomes, the ICU length of stay went from 12 days to 6 days. The hospital length of stay went from 65 days to 44 days on median. So this is quite long lengths of stay, might represent differences in the hospital functions and lengths of stay. And the outcome at hospital discharge. So significantly more patients were able to discharge home and to the community rather than to another rehab hospital or another hospital compared to phase 1. So pretty dramatic results. I'm just going to end with a few case studies, and I'll try to do these quickly, but I think they're quite interesting, and usually people enjoy seeing these. All of these names and media are shared with consent from the patient. So this is Amal. I'll show you a video. She was admitted to an outside hospital with the flu and ARDS. She delivered a baby while on ECMO with a C-section. She was proned, and she was on ECMO for 26 days before she came to our hospital. She had a very long run of ECMO, 278 days at our hospital on ECMO, and she was in the hospital for 366 days. Physical therapy evaluation happened on day 1. She had about 1 out of 5 strength in her limbs, and it was a passive transfer to a chair. We had 154 PT sessions while she was on ECMO. The majority of them was with femoral jugular configuration. So we have seen hundreds of mobility sessions with femoral cannulation of ECMO that has been done safely and with very, very, very low rates of safety events. She walked in 112 ambulatory PT sessions with a distance up to a max of 280 meters. She was on the lung transplant list for most of this time. However, she was able to get off ECMO, to get off mechanical ventilation, and she went to rehab. So I think, yeah, here's the video.
Okay, right? Just a little bit difficult? Yes. Perfect. 4.
So here is a graph of her trajectory using the ICU mobility score that was mentioned in the last lecture over the 154 sessions on ECMO. And as you can see, there was a lot of improvement in the first phase, and then she really maintained the majority of sessions being ambulatory through the course of her care. I will quickly go through these. This is a patient who came from India for a lung transplant. I think he was on ECMO for 3 weeks or so. He went home independent afterwards. Again, he had femoral jugular VV ECMO. And on event, as well as the last patient on event as well. He was very happy when he walked. And then the second video is just before discharge. Sorry, there's some overlap of these videos. This patient is 19 years old with end-stage heart failure. He had an LVAD, a BiVAD with CentraMag, mechanical ventilation most of the time while he waited for a heart transplant, more than a year in the hospital, extremely weak, finally got his heart transplant and was discharged home. This is a phase where he's very, very weak. And the second video, just sitting by himself was a big, big improvement. Okay, I will skip through these for the sake of time. This is Zayed recently, last week in his home gym, doing great. Okay, I won't share these. I think we've run out of time, but thank you. Good outcomes for our patients. That's what we're always working for. Thank you, everyone.
Thank you so much, Aaron, for this very nice presentation. Now, Professor Heba Al-Jibali is going to give 8-minute case-based discussion We all love the case-based discussion and this, nice video that was introduced by Dr. Aaron. So let's try if we can learn from Professor Heba El-Jibali case-based discussion.
Hello, everyone. My name is Hibatullah Asal, Professor of Chest Diseases, Cairo University. Today's case is about a female 68-year-old diabetic patient. She was brought to the emergency room because of shortness of breath, malaise, and confusion. She was intubated emergently due to severe respiratory distress. She was admitted to the ICU with a diagnosis of septic shock resulting from community-acquired pneumonia with an exacerbation of COPD. Her husband reported that she retired from her job 3 years previously and was physically active, walking on a treadmill for 30 minutes about 3 times a week and also gardening. In the ICU, the initial ventilator settings were FiO2 of 0.7, PEEP of 10 with lung protective ventilation with norepinephrine requirements of 8 mic per minute. She received as needed fentanyl with propofol targeting a Richmond agitation sedation scale of 0 to -1. Over the next 18 hours, the patient's ventilator settings improved to FiO2 of 0.5, PEEP of 8, and norepinephrine requirements of 2 mic per minute. On interdisciplinary morning rounds, the patient underwent a spontaneous awakening trial, but failed the spontaneous breathing trial because of tachypnea. The responsible physician asked for physical therapist assessment and consecutive management of an expected ICU-acquired weakness being a possible cause of difficult weaning. The physical therapist reports that the patient has good muscle reserve and does not have ICU-acquired weakness. What is the objective method the physical therapist relied on in such a case? Is it Medical Research Council sum score of more than 54, Medical Research Council sum score of less than 48, Modified Medical Research Council grade 4, muscle biopsy? The second question, if the patient later on developed ICU-acquired weakness, what will be the possible risk factor in such a case? Old age, female gender, use of vasoactive medications, sepsis, all of the above. Although the patient was still mechanically ventilated, the physical therapist recommended to start an early mobilization protocol to assist the patient in increasing her mobility level in tolerable increments. The protocol was based on 4 levels of increasing mobility according to the patient's tolerance, starting with simple passive range of motion, shifting to sitting on edge of the bed, and finally encouraging the patient to ambulate. The patient now is conscious and can follow commands: ventilator setting, CMV, volume control mode, FiO2 0.5, PEEP of 8, norepinephrine requirements of 2 mic per minute. In your opinion, what would be the best timing to start such a mobilization protocol? Should we start currently while the patient is still on mechanical ventilation in the current clinical situation with reasonable oxygen requirements and low dose norepinephrine and she is conscious? Or should we start after the patient is weaned off mechanical ventilation? Or should we start after stopping vasoactive medications? Now we go to the answers. Regarding question number 1, which is the objective diagnostic method the physical therapist relied to assess this patient and say that the patient has no ICU-acquired weakness, the correct answer is the first one, which is Medical Research Council sum score of more than 54. So ICU-acquired weakness is defined as clinically detected weakness in critically ill patients in whom there is no possible etiology other than critical illness. It presents as generalized symmetrical weakness, predominantly involving proximal limb muscles and respiratory muscles, sparing the ocular and facial muscles. The diagnosis of this entity is challenging. For patients who are awake and following commands, use of medical research council scale is recommended to grade the patient's strength. The muscles tested include wrist flexion, forearm flexion, shoulder abduction, ankle dorsiflexion, knee extension, and hip flexion. Grades for each muscle are from 0, where 0 denotes no visible contraction, to 5, normal strength. A total score of less than or equal 48 with symmetrical weakness is diagnostic of ICU-acquired weakness after exclusion of other causes. In this patient, her score was more than 54. So a score of more than 54 is considered the patient did not develop ICU-acquired weakness yet. So answer A is correct. Muscle and nerve biopsy can provide important information but are too invasive for regular use and generally not used outside of research. So answer D is incorrect. This is the score that is used. These are the 6 movements that are tested and given numbers from 0 to 5 according to 0, no movement, 1, flicker of movement, 2, movement with gravity eliminated, 3, movement against gravity, 4, movement against resistance, and 5, normal power. So these movements are assessed in the right part and in the left part, and the total sum score, if all movements are normal, should be maximum 60. What are the possible risk factors for developing ICU-acquired weakness in such a case? The answer here is all of the above, where old age, female gender, use of vasoactive medications, and sepsis are all reported to be risk factors for developing ICU-acquired weakness. According to the literature, the non-modifiable risk factors that were associated with developing the ICU-acquired weakness were old age, female sex, obesity, sepsis, and multiple organ failure. The modifiable risk factors are hyperglycemia, administration of early parenteral nutrition, immobility, use of certain medications, vasoactive medications, vancomycin, and aminoglycosides, prolonged and deep sedation in mechanically ventilated patients, and corticosteroid use. The third question, which is the best timing to start the mobilization protocol in such a patient, is the first answer, which is currently, while the patient is still on mechanical ventilation in the current clinical situation, where the patient is more or less stable with low dose vasoactive medication requirement and accepted FiO2 or oxygen requirement with PEEP of 8, the patient is conscious and follow commands. So this is a good timing to start mobilization protocols. So timing of mobilization play a large role in the efficacy of mobilization program, given the known rapidity with which muscle wasting occurs in critical illness. Studies that enrolled patients to mobilize on an average 1.5 days after initiation of mechanical ventilation had much better outcomes to studies that mobilized the patient first 3 to 4 days after ICU admission or 8 days after mechanical ventilation. So answer A is correct. Studies had shown that mobilization with norepinephrine can be done safely when considering the status of the patient and safety guideline. And thank you.
Very nice. Thank you so much, Professor Heba. And before opening the QA session, I just want to highlight a couple things. First, studies have showed that about 40% reduction of muscle cross-sectional area happen within the first 3 to 4 weeks of ICU stay. And the muscle strength can decline by about 3 to 4% every day. Every day, the muscle strength goes 3 to 4% down, especially in the first couple weeks of ICU admission. By 1 month, many patients would have severe sarcopenia, and they don't only lose muscle, they lose bone too, what we called osteosarcopenia. Then they will have higher risk of fracture, higher risk of falls, And also this is going to delay their extubation, and they will be dependent more on the ventilator because of the muscle weakness of the respiratory muscle. So it's very pivotal. It's very important, I think, to do everything possible to avoid sarcopenia, muscle loss, osteosarcopenia with bone loss as well. With that, I'm going to let Dr. Muhammad Al-Ammari to start the Q session with our first question.
Yes, Assalamu alaikum. Thank you so much, guys, for these excellent talks. I think this is a huge problem. It's something that I think it starts with us recognizing that this is a problem as physicians in the ICU, and then trying to engage our physical therapists on day one. I think the challenge that many of us face is that we don't have dedicated physical therapists in the ICU. This is the challenge I have in my hospital, and unless we, reach out to the leaderships and the people that can change this in hospitals, and ask for dedicated physical therapists to be present during the MDT rounds, and not just during rounds, but even post rounds, where they have to go about and look at those patients who will benefit the most from physical therapy. Unless we do this, I don't think this is going to be a problem that will increase the length of stay, ventilator days, and cost, of course. We have a few questions that came from the audience, and the first question is from Shema Abdul Hamid, I guess, and this is a question to the esteemed speakers. Our problem in the ICU with physical therapists, that most of the time they refuse to mobilize patients due to the fear of tachycardia or increased blood pressure. I guess the fear that the patient will become unstable once they move them out of the bed. Aaron, Dr. Mustafa, Dr. Hiba.
Yes. Yes, I think when you are starting to initiate something like RACSO protocol in your ICU or early mobilization for the patient, you have to choose champions from each team. Yeah, actually, we have chosen. We faced this problem a few years back, and we started with, as Aaron said, two physiotherapists. They were our champions in the ICU. They started the program. They had a lot of courage, a lot of willing to initiate this program with us. And after that, every physiotherapist, every nurse, every RT in the ICU will follow the first steps. The problem will be the first steps. And you have criteria for safety. If the blood pressure increased more or increased more than 40 or decreased less than mean 60 millimeter mercury, physician should be attending and close to the patient, especially high-risk patients, saturation, any monitor. You can exhaust any monitor in ICU during mobilizing, especially high-risk patient, like patient on ECMO. It's very tough to mobilize patient with ECMO, but it's achievable. If you are cautious, you are monitoring well your patient, and you are going the process early and gradually, you will achieve it.
Anybody else wants to add to this?
I would mostly just concur with what was said. I think starting with establishing those inclusion, exclusion criteria as a team, so that people have the same understanding of what's trying to be achieved, and reassuring. The ICU is the place where you have more information in real time than anywhere else. So the moment that things begin to change hemodynamically, and you can make a decision about continuing or not continuing. And you may be more conservative in the beginning if you really have staff that are not experienced or fearful. But again, also, as it was mentioned, if a physician can be near, offer support, you talk through these cases. And then I think really finding success stories, even just a small moment maybe that was successful, and really promoting that across to more people, because we want our patients to get better, and seeing the outcome can sometimes help mitigate those fears when you see the success and when the team reflects on them. So I think team reflection is sometimes helpful as well.
Totally agree. And again, I think once you have a dedicated team that's familiar with the ICU, who attend rounds and actually hear it from during the discussion of the plan of the day, that this patient is for physical therapy. We need to focus on this guy. These therapists will feel more mobilizing rounds, and most of the ICUs in most of the world are, they have intensivists 24/7. So if the therapist knows that they have the backup of the physician who come in and the patient, I mean, I don't think this is going to be a problem. So engaging and empowering our therapists should solve this problem. Dr.
I
Murad,
would
you want to
also
go to you want to
reiterate
take the question?
real
Go
fast.
ahead.
I would also just agree that the importance of having dedicated therapists in the ICU, because if therapists have
Yep.
if they're covering ICU and wards, we will always get pulled to the discharges, the difficult things happening up on the ward. The urgency of ICU is harder sometimes to justify on a daily basis, although it is urgent. So if you can restructure teams to get therapists dedicated to the ICU, because that will also allow them to develop the depth of knowledge and exposure that's required. This is very much a specialty area where you need to spend a lot of time to get all the basics and then the advanced things. And it will not happen if your therapists are covering up and down the hospital, across the hospital, in many different places.
Okay.
And it takes some skills to mobilize somebody on ECMO or somebody with a balloon pump. So when you have dedicated team, these guys will get, will continue to practice these skills, and rather than having a therapist that comes and goes, who's not going to be familiar with these things. So dedicated, I think a dedicated physical therapist, critical care therapy team is the answer to this problem. But again, it's a problem that we will continue to face because of resources.
So Abdul Rashid is asking, how's your experience with autonomic dysfunction and postural changes in patients who are suffering in the ICU? I think I could probably start by give a brief answer, and then we'll see what our speakers think about that. GPS is a very common disease in the ICU, or neuromuscular weakness, as we call them, and patients usually very commonly get to have some sort of autonomic dysfunction. It's very difficult to treat. Majority of these patients will have fluctuation in their heart rate and blood pressure. But again, there is no consensus, or there is no agreement on like what number should we follow. Even if patients are on low dose vasopressors, still, if they're stable in the last couple of hours, no big changes, we still advise our physical therapy team to ambulate them. It's very essential. So even with autonomic dysfunction, if it's not causing huge fluctuations or acute changes, I would still be okay with them ambulating and starting physical therapy as soon as they're medically stable. Any other thoughts?
I think
Yes,
you have a consensus on that. Thank you so much, Dr. Murad, and thank you everyone who participated, and of course, thanks for our attendees today. Just some few closing remarks. All of the attendees should receive certificates by next week. And by tomorrow, you should all receive the YouTube link for our recorded webinar. Again, if you are interested to join our fellowship program, please go ahead and do, and please take advantage on the 10% discount using promo code webinar10. And have a good rest of your day, your night, your afternoon. Bye.
Thank you so much.
Mhm.
Y'all have a good day.
Thank you.
Thank you.